Here we go. So I'm gonna start with a case about a 14-year-old white male who came to the Department of Oral Medicine of the University of Washington with a chief complaint of not being able to eat or drink because of generalized oral ulcers and sloughing epithelium that had been present for 8 weeks. The ulcers started at the mucosal area of the lower inner lip and later spread to his entire mouth except for the outer lips. This included the gingiva, bilateral buccal mucosa and vestibules, the floor of the mouth, the soft palate, throat, and inner lips. This was a clinical view of the lesions at the first week, demonstrating generalized ulceration of the lower lip. The ulcers are superficial and irregular and or covered with pseudomembrane. This is a clinical view of the lesion at the second week, demonstrating generalized ulceration of the mandibular vestibule and buccal mucosa. Like the other areas of the mouth, the ulcers are superficial and irregular and are covered by pseudomembrane. Generalized ulceration of the floor of the mouth, ulceration of the uvula and soft palate area. As I said before, the ulcers started at the mucosal area of the lower inner lip and later spread to his entire mouth. Extraorally, he developed sores in his left eye, which responded to eye drops and ointments, and later in his right eye, which responded to anti-inflammatory ointment but decayed. The patient's past medical history is significant for asthma, which he has outgrown. His family history is significant for eczema and thyroid autoimmune disease. The hematoxylin and eosin stained frozen section showed evidence of a split above the basal cell layer, as well as areas of acantholysis. The connective tissue was infiltrated by lymphocytes, plasma cells, and neutrophils. The direct immunofluorescence antibody staining was positive for IgG and C3 antibodies and was also focally positive with antibodies to fibrinogen. The positive IgG and C3 staining was pericellular and intracellular, involving the epithelial cells above the basal cell layers. After we have finished reviewing the available diagnostic information, the diagnosis is Pemphigus vulgaris. Although Pemphigus vulgaris is much more common in adult female patients, it can occur but rarely in children. Pemphigus refers to autoimmune disorders, mucocutaneous blistering disease, in which the keratinocyte antigens are targets of autoantibodies, leading to acantholysis and blister formation. PV is a life-threatening vascular bolus disease that affects skin and mucous membranes. Present with oral lesions and then develop cutaneous lesions, predominate in women 50 to 70-year-old. Common sites: oral mucosa, skin, nose, pharynx, larynx, esophagus, genital area. Most common on buccal mucosa, followed by palate and gingiva. Mortality rate is 6%. Intact bulla rare due to fragility. Patchy erosions are seen, painful on chewing. Desquamated gingivitis 2 to 3%, and these are some photos for its commonest sites. Positive Nikolsky sign: the upper dermis separates from the basal layer. Presence of Zank cells, which are multinucleated giant cells formed by the fusion of acantholytic keratinocytes. Split is characteristically supravascular and cells remain attached to basal laminas that give tombstone appearance. The IgG antibodies which target desmoglein 3 are deposited at the periphery of the epithelial cells, resulting in chicken wire appearance. Treatment: lower doses of prednisolone and topical steroid for oral PV, high doses of prednisolone combined later with steroid-sparing immunosuppressant for oral and skin PV. Rituximab is effective in resistant cases. Thank you.